Good afternoon, everyone. I'm Anu Rangarajan, the Director of the Center for International Policy Research and Evaluation at Mathematica. And I have the pleasure of introducing our speakers for the forum today on integrating health, nutrition, and early childhood practice worldwide. First, I'd like to say a few words about the Center for International Policy Research, which is hosting this event. As many of you know, Mathematica has designed and conducted rigorous evaluations of complex social programs domestically for over 45 years. And in the last 10, 15 years, we have used this depth of experience to conduct rigorous and high-quality research in the development sector. With our work spanning a lot of different areas in the development sector broadly, and work spanning more than 40 countries in Africa, Asia, and the Latin American and Caribbean region. Last year, we created the Center for International Policy Research and Evaluation to oversee all of our international projects and to contribute to building to the evidence base and improving the evidence base in international development. Disseminating findings from studies and bringing together researchers, policymakers, donors, and various stakeholders is an important goal of the center. And today, we're very pleased to have the first forum, CPRI forum, on this important topic related to integrating health, nutrition, and early childhood development interventions globally. So, just to kind of give a little bit of framing for the discussion, over the past 10, 20 years, the international community has seen incredible improvements in child survival and child health as a result of a range of interventions focused on improved vaccines, providing better access to health facilities, access to health care, improved nutrition knowledge, behavior change interventions, and so on, which has led to reduced child illnesses, deaths, and improved child health and nutrition outcomes. At the same time, we've seen increased recognition of the importance of early childhood development-focused interventions, such as stimulating the child, more mother-child interactions, and so on, particularly during early months of the child's life. However, we haven't seen as much integration of efforts across these sectors, and only more recently are we starting to see some of the efforts, both in terms of the interventions and the research that brings together these sectors. This forum focuses on why integration is important, what the recent research suggests, what the challenges and opportunities are as we think about integration across these sectors, and how researchers and practitioners can work together to learn more and to move this agenda forward. So a quick look at the agenda. We'll first hear from our distinguished panel of speakers, which will be followed by a discussion moderated by Mathematica Senior Fellow Kim Bowler, who's an expert in early childhood development. We'll have a lot of opportunities for Q&A, and I would like to encourage all the webinar participants to electronically send in your questions as the speakers are presenting their work, and also when Kim is moderating the discussion session later. So our panelists, I'm pleased to introduce our panelists today who bring their experience from across the globe. Dr. Harold Alderman is a senior researcher at the International Food Policy Research Institute, where his current research focuses on the links between nutrition and early childhood development and the means by which nutrition and social protection programs contribute to long-term economic growth. Prior to rejoining IFPRI, Dr. Alderman was at the World Bank, where he divided his time between the Development Research Group and Africa regions, where he advised on social protection policy. There's more details on their bios in your folders, which you can take a look at. Dr. Mandana Arabi is the Executive Director of the Sackler Institute for Nutrition Science at the New York Academy of Science. She has facilitated nutrition programming in more than 15 countries, dealing with the double burden of over and undernutrition. Dr. Arabi's research and programmatic work has addressed infant and child nutrition in developing countries, as well as the impact of globalization and broader social and economic factors on nutrition and health in vulnerable populations. She has worked as a nutrition advisor with the Ministry of Health and the World Bank in Iran, as well as a nutrition advisor for infants and young children at UNICEF. Finally, Dr. Emiliana Vegas is the Chief of Education Division at the Inter-American Development Bank in Washington, where she oversees the bank's lending and analytical operations to support education systems throughout Latin American and Caribbean region. Previously, she was at the World Bank as the lead economist and human development sector leader for Central America and the lead economist in education unit of the Human Development Department. So with that, I will turn it over to Dr. Harold Alderman, who will bring his perspectives on integrating early childhood stimulation.
Thank you. I'd like to summarize ECD in one slide. This is from the Lancet series, recent Lancet series. What we can see is that when the protective factors are greater than risk factors, you get greater development with, and this is important for the integration, the first 2 years of life, the difference between those who have the protective factors and those who have high risk factors widens. Now, in somewhat contrast to nutrition, it is possible, the evidence shows that a child who has fallen behind can catch up in child development easier than they can catch up in height. So this is an important policy implication that there's real evidence that programs can do something to enhance that catch-up. Now, we know that the peak vulnerability for nutrition and the peak vulnerability for ECD occur at the same times. The brain is growing fast, the whole body is growing fast. However, knowing that the peak vulnerabilities are at the same time does not necessarily mean that the best cost-effective programs are at the same age targets. And that is the challenge, the dilemma a bit for integrating nutrition and ECD. No question on the timing of stunting. I'm sure you've all heard it. There's a lot of discussion on the first 1,000 days, and that's based a bit on the evidence on intrauterine growth retardation that's come up in the recent Lancet issue series on nutrition, emphasize that. There's a lot of studies of global patterning of faulting. Growth stunting occurs very early, in the first 6 months. That's a bit of a surprise, and levels off in a population at 2. There's a bit of a debate now whether or not there is catch-up after 2, and there's certain evidence that there is. However, there's less evidence that you can do anything about it. It happens. But how do we make it happen, the catch-up? There's less evidence. Right now, the growth response to supplementation is obvious at weaning age. It's not obvious at other ages, particularly when there's a risk of trying to catch up on growth, on physical growth after 24-month risks obesity over a lifetime. So we don't know what to do about that. I would actually say, and I've used the 1,200-day period because of the importance of preconception. People say, why 1,200, why not 1,500? But the point is that there's a focus on adolescence as well as on period right after conception, the first 1,000 days. Now, just to show you that there's a lot of nuances on what age to deal with, a particular set of studies put together. There's studies that show, we know that iron and iodine are important in prenatal. There's at least a set of studies from Nepal that show prenatal iron leads to the child at age 7 having higher cognitive, but iron at weaning age doesn't. It's not clear why, to me at least. It's not my area of research, but it shows you a very interesting pattern of age dependencies of programs. When is the right age, the best age to intervene, is very nuanced. And that's, of course, very important to the entire question of overlapping of programs. This is showing you that what we know about the age pattern of cognitive developments. You show sensitory, you show language, and you show higher cognitive functions. Now, anybody who has a teenager knows that it takes a longer time than 16 to go there. But anyhow, language. Now, I'm not sure if this is as clear as it should be. This is the first year. Language development. You are losing neurons before you ever speak. And this is very important because in many cultures, you don't talk to a child who's 1 year old. You coo, you show them love. But you don't have conversations, you don't tell them stories because they don't have a language ability, or so they think. That's one of the reasons why the integration in the first 1,000 days with ECD is a high priority. There's other reasons, but this is one that I find very striking. So I've mentioned we've got to take the age responsiveness to interventions. And that would give us some guide, because certain programs that are both nutrition programs and ECD programs are very clear. As I mentioned, iron and iodine are one, but dealing with maternal depression, it's pretty clear that if you can address maternal depression, and there's a few studies from South Asia show you can. It's not, again, universal. We don't know exactly how to do it at scale or so forth. But if you can do that, it will affect the survival of the child, the physical growth of the child, and the cognitive and social emotional. All of that will happen if you can address the underlying risk factor of maternal depression. But home stimulation, which can affect cognitive development and is also very similar to home visits for growth promotion, turns out it's very hard to do at scale. The amount of training that's required, the supervision, the fact that nutrition is usually run from a different unit in governments in many cases, as is education and stimulation. For various reasons, it's not easy to run at scale. There's some decent evidence that you can do it on the clinical level, 100, 200 children's type of study. At scale, there's less of. Parental enrichment in group sessions, which can be used both to encourage stimulation and to uncover better weaning or so forth. That again, there's evidence on, but again, less at scale than I'd be comfortable with at least. And I must say there's another risk to consider: overloading the mother with too many messages. There's a study from Andhra Pradesh in India where they're doing responsive feeding, which can improve both growth of a child, physical growth and cognitive growth. They found that a few simple messages was more effective than adding messages. And that, of course, is a programmatic risk that has to be considered. The evidence on program synergy, this is what my concern is. There is evidence, but it's right now not so much at scale. The best known study, Jamaica, has been followed now till the people are adults. Just last month in Science magazine, a team of psychologists and economists showed 25% higher earnings when these children were adults. And they've shown in between that they were able to work with the children who were malnourished, and if they got the stimulation, they had similar cognitive, social, emotional development as the children who were not malnourished. Conversely, if they did not work with the malnourished children, they stayed behind. So that shows that you can target to high-risk children and close the social-emotional gap and the cognitive gap without closing necessarily the height deficit. But in general, when you've done nutrition, even in the small-scale programs, and ECD at the same time, you might get improvements in heights or zinc or iron, and you might get growth and you might get cognitive, but you don't get synergy. That is, you don't get something which shows when you have both programs together, you get more than the sum of the individual parts. That hasn't been shown in most of the literature that I'm familiar with. Now, I would say that trying to provide stimulation and preventative nutrition, as I told Jamaica, they were already malnourished, some studies from Bangladesh the same. There is one very recent study that say adding stimulation to a ongoing lady health visitor project in Pakistan. We're hoping actually that one of the principals of that we're going to be here, but she couldn't make it, seems to have a additive impact with very early at the preventative level rather than, as I said, the catch-up level. But that's a single study, and it'd be great to see that replicated. Okay, I should say, when we're talking about synergy, it doesn't mean that you can still have synergy without actual better than additive effects, because it would cost less to have a combined set of interventions than the individual ones, so that your benefit cost ratio, if the cost is less from summing them, even if the benefits are just the sum, which is not such a bad deal, you get a higher benefit cost ratio. And there is no evidence in the literature reviewed that I've seen that adding two programs at the same time have a detrimental effect. I'm talking not so much about the messages, where there is a little bit of a problem, but as far as adding supplementary food and stimulation, there's no evidence that I know of that having those two programs combined undermines either of them. Administrative overload, usual things like that could undermine it, but there's no evidence for that. But I'd like to say that if nutrition is going to focus on the 1,000 days, which would prevent malnutrition and prevent many of that gap that I showed in my first slide, there's a problem from integration that we have to consider. We have sets of programs for the first 1,000 days. Preschool programs are being established at a greater rate all over the world. Even in Africa now, they resisted because they had teacher shortages, but now there are a number of programs in Africa that are trying to scale up preschool. So first 1,000 days takes the child to age 2. Preschools takes them at 4 and 5. There's little out there between 2 and 4, and most studies show that without follow-up for cognitive development, waiting between 2 and 4 years of age will lose some of the potential that's been established by having stimulation programs and parental enrichment prior. So there is that gap that if you're going to talk about integrating nutrition and ECD, what you have to consider is passing the baton on from different responsibilities. Okay, I'll stop here and pass the baton on to another.
Hello, thank you very much everyone for being here today. So I'm going to talk about some of the work that at the Sackler Institute for Nutrition Science we led in order to bring the literature together in a special issue of Annals of New York Academy of Sciences, and with a special focus on integrating nutrition and early childhood development interventions. And finally to find out what we know in the literature and in the studies right now about what works. Just to give you a little bit of background about where it came from, at the Sackler Institute for Nutrition Science, we started by developing a collaboration with the World Health Organization to look at the field of nutrition science and to find out what are some big areas of research gap and evidence gap that still exist in nutrition and stop us from making progress. And we really need to make a leap in addressing both over and undernutrition with the current burden that we have globally, more than 2 billion people being affected by the spectrum of the malnutrition condition. So in order to do that, we really engaged a lot of thought leaders, and we brought together experts to tell us what they feel that the major gaps are in nutrition and the related sectors. And one of the major gaps was related to integration of nutrition and early childhood development, and really defining early childhood growth and development as the comprehensive aspect of well-being of children in early ages and what that takes, which would be physical as well as mental well-being. So in order to address this research gap, in 2012 we brought a group of experts together for an early consultation. And we try to go beyond the usual experts who work with us in the field of nutrition. We engage early childhood development scientists, public health economics, and also related disciplines in human development. The group came together and tried to really define the focus of what they want to work together on around some major issues that they feel that they need to address as a community working together on integration. They wanted to find out, are integrated interventions associating early childhood development and nutrition, health, water and environmental sanitation, and other related objectives more effective in addressing suboptimal child growth and development? Basically, really, can we show that integration makes these interventions more effective? What's the evidence across disciplines on what works and what does not, and what causes interventions either to succeed or fail? So let's really look at across the disciplines, try to tease out some common themes for success or maybe failure so that we can really lead programming in future better. And how can successful integrated interventions be brought up to scale within current delivery systems? So we identified some key themes, and around these papers were being developed. And at the end of this process in April of 2013, we had a public conference, a forum where the papers were presented. And this led to the publication of the special issue of Annals of the New York Academy of Sciences, which is dedicated to the memory of Dr. Pat Engel, who was a leader in this field, really also working on the intersection of nutrition and child development for a long time. So this issue, every child's potential, integrating nutrition and early childhood development interventions, has been published now. It's edited by Dr. Maureen Black and Dr. Kay Dewey. So again, this is for us kind of an interesting way of bringing the two disciplines together by having editors coming from each of the different disciplinary perspectives, but really looking at what are the common areas and themes for integration. As I mentioned, it's available online. You can easily just Google every child's potential at Wiley, and you will be able to access all these articles and download them. There are 20 papers. And we were able to launch this series, the special issue at UNICEF earlier this year. Some of the themes that were identified across these papers, and I felt that it would be relevant to today's discussion. There's generally, we did our best to really take a stock of what's available out there and to bring the key experts that are well recognized and are doing great work in the field. There is limited evidence on development, implementation, evaluation, and scaling up of integrated interventions. We had really good, exciting studies. Some of them were presented, some of them are underway, and some of them have been evaluated. But in general, there is still room for work. Most integrated interventions have not formally been evaluated for the synergistic effects. And I think this really relates to what Harold was talking about earlier, the fact that, well, we haven't had a lot of examples of being able to show synergism. But what I want to talk about now is, do we really think that we have had the design that would allow us to capture the synergistic effects? And I think, at least for me, coming from the field of nutrition, I don't think that's really been a main focus for evaluations that we've done. And I think probably we needed to have different perspectives, have different evaluation mechanisms, and maybe look at some different indicators or some intermediary factors to actually be able to capture what is the synergism that you're talking about. What are some added elements when you bring two different programmatic perspectives together? Maybe you have some other win areas. Maybe you're improving empowerment or improving the quality of programs. Even within the field of nutrition, we have just started looking at the synergistic effects of nutrition-focused interventions. Just as an example, I was involved in a study that UNICEF helped in India, and that study looked at how adding a micronutrient supplementation to a nutrition behavior change program in the context of the integrated child development services in India would really affect that program. And there were some signs that, giving the supplement, of course the supplement itself has some nutrient contents and, iron status changes and all of that. But even the fact that there was some element added to this program, there were some signs that the overall uptake of the program improved. There was additional supervision for the program, which probably improved the quality, but also probably the recipient's perception of the value of what they were getting because of the improved package changed. So, when you talk about capturing synergism or capturing the additive effect of adding interventions to each other, you can actually start thinking about what would be the added elements to the program and to be able to actually capture the synergistic impact. So I think that's an important issue to be aware of. I won't focus on the Jamaica study or the design. So usually the design is, okay, you have one intervention, the other one, and then you see whether you add them together. There are any additive or synergistic effects. The other way of looking at programs also is not thinking of these interventions as separate entities that, okay, we are now delivering them together or in a parallel way, but really looking at them as conceptually similar or conceptually being integrated together. And I think, again, in my field, which is early infant and young child nutrition and interventions for early infant and young child growth, this theoretically also makes a lot of sense. I mean, how do you separate? Like, breastfeeding is not only, to me, a nutrition intervention, but it's probably a stimulation intervention as well. There's a lot of interaction between mother and child. So there is really a conceptual, a kind of theoretical integration of the concept. And with these kinds of intervention design, you probably don't even want to or have to actually then say, okay, what would the breastfeeding without a stimulation look like, and now adding a stimulation? This is really about actually thinking about an integrated approach to addressing child development needs early in life. And I just wanted to mention a tool that has been developed that allows to having this integrated approach to developing messaging, for example, and this is the process for promotion of child feeding that was led by Pan American Health Organization and UNICEF. It's a tool focused on addressing the gaps in infant and young child feeding practices and then coming up with specific interventions designed to address those. And I think a very important gain for this 1,000 days, as we call it, the first 2 years of life, is that the guiding principles for feeding infant and young children already has responsive feeding as one of the principles. It's already integrated. You actually count this as one of the principles of feeding infants. So that's one of those examples where the concepts are already integrated. It's not really just parallel delivery, it's actually integration of the concept itself. I also wanted to just talk about some examples of the programs that this issue looked at. We had several examples. The Pakistan study, there were quite a few from countries that are looking at, again, parallel delivery or sometimes integrated interventions in the program context. Here I just wanted to highlight for you, what we have come out of Bangladesh, because to me this was an example of how the field is moving forward. The review in this paper that was published in the series looked at 7 randomized controlled trials and 3 program evaluations coming all out of Bangladesh. And it's all the result of the fact that early childhood development has been included in the national plan of action in the country. So in a way, you have the macro level thinking already there. And from that macro level thinking and inclusion in the national plan, there are micro level program initiatives that have been developed and evaluated. Most of these programs, the criteria basically for this review was they included any program that had a structured child assimilation and preschool in it. It had at least 3 months duration. It was integrated with health and nutrition, and it had at least an evaluation. So these were the programs that they looked at across the country. And overall, it showed that, yes, it is feasible. It can be done effectively, so that's a good sign. But there were also a lot of recommendations for how you can improve these programs. There needs to be better development of messages and curricula so that adding additional elements doesn't really overburden the system and allows us to actually still efficiently and effectively deliver the program. There needs to be a much broader stakeholder and partners involvement because you're talking about engaging multiple sectors. The issue of the role of women in just bringing everything together and caring for children definitely is something that's always highlighted, and we have to take advantage of a perspective that allows us to include women's empowerment to benefit nutrition, child development, and many other positive practices, care practices. This all shows, though, that there is a need for systematic evaluation of how these macro level improvements in integrative approaches become translated and become really implemented at the micro level. So here you have the macro level idea. You feel like the national plan is comprehensive, it has the elements, but the continuum of taking this to a scale in a uniform, systematic way and evaluate it in a uniform, systematic way is still not there. You have still the sporadic programs or kind of different variable interventions that are there. So for scaling up, I think overall we still need to have a much better idea of how we can look at integration in a more systematic way so we can capture all the elements of integration. Some other issues that came up out of the summary, and I won't focus on the ones that are repeated, is Generally the issue of training, supervision, capacity building, the fact that all these behavior change interventions in general need a lot more focus on coaching and didactic approaches rather than just developing messages that are unilateral and delivering messages to the recipients. And my final focus is just looking at the series, at the papers, and as I said, the spectrum of what's happening from the policy level all the way to the macro level implementation. I think that we really are moving in the right direction, at least from the nutrition. I think it's well understood and supported that child development is an integral part, excuse me, an integral part of nutrition interventions for early childhood. That's a given. But we really need to better capture how the whole system is going to function with all these different elements together. Health, nutrition, child development, and water, environmental sanitation, and all these close interventions that will be developed as a package in early childhood. Again, there were some recommendations through this process to use systems research, implementation science frameworks that would allow us to better understand these interlinkages, the macro-micro connections, and where the bottlenecks exist for delivery. And really the final big message is also capacity development. Even for doing this kind of research on integrated approaches, I think you need to have scientists who have a better understanding of interdisciplinary approaches, are able to actually look at indicators. In a lot of studies, it's either focused on child development and there's some afterthought on nutrition, or it's focused on nutrition and there are some elements of child development. They try to include it, but it's really not as strong as it can be. So I think we can still make a lot of progress in developing better scientists who can have an integrated approach to implementing research as well. So thank you very much for your time, and I'll be happy to also have a discussion later. Thank you.
Does it come up or? Thank you so much. I am delighted to be here. Thank you, Kim and Anu, for inviting me, and obviously Amanda as well. I was given what we all agreed was probably the most difficult question, because there's really no evidence on how to address the important challenge of integrating health and early childhood practices. So my presentation is a little bit different than those that preceded. The two questions that I was asked to address were what are the challenges that get in the way of integration, and how can they be addressed? And when is integrated programming the best approach, and when may it not be? So I'm going to start by giving some definitions so that we know what we're talking about. I feel like a lot of times when we talk about early childhood development, we have different ages in mind. Some people think it's 0 to 6. Some people think 0 to 8. So in this presentation, I'm going to refer to it as 0 to 8, meaning from conception to when the child is 8. We go a little bit farther because I work in education, and those first few years of elementary school are still very important for building basic skills. Still a time in life when the brain is developing quickly, and so we want to make sure that children are getting the right programs and interventions in time. There's also a distinction I want to make between programs and policies. The two previous presentations really, I think, refer to programs and interventions that are designed to solve or address a specific issue. And they may vary. They might be a nutrition intervention, there might be an integrated intervention, but they're still seen as a program, and you might have a core group of people designing that particular intervention and implementing it. And I want to distinguish that from policies because we have less knowledge, but a lot of countries, at least in the region that I work in, Latin America and the Caribbean, are really focused on how to develop a framework for early childhood development, how to have regulations that protect the child but also intervene when the child needs to in a host of different sectors, from nutrition, health, education, and social protection. And that may be at the national or subnational level. And so if we simplify a little bit, what sectors intervene or may intervene, and who are the targets of these interventions? So, you think of the child as the main target when he's in utero, prenatal, but also in these different age groups, 0 to 2, 3 to 5, 6 to 8. But the mother also is a big target, particularly when she's carrying the baby, but also postnatal, and Harold referred to maternal depression, so that also affects the child. and also the caregiver, the mother, the father, an external caregiver. And then in terms of programs, I have to start with education. It doesn't mean it's more important for everyone, but early schooling, preschool, and early care. But also poverty alleviation. We know that one of the key factors that affect early childhood are just the availability of resources. And so a lot of countries in Latin America, but also elsewhere, have done a lot in terms of attacking early childhood by providing income transfers, maternity, paternity leave policies, trying to entice female labor for participation, but accompanying that with adequate care and addressing issues of poor home infrastructure. And then also, of course, interventions from the healthcare and hygiene area and from nutrition, which you heard quite a lot. And I guess the big challenge is when we think about the young child and the baby and then the child who's getting older and growing, how to ensure that they grow in all these respects, both physically, emotionally, as well as cognitively. And here is where I'm going to turn a little bit to specific program characteristics. In my previous job at the World Bank, we did an effort to try and systematize how to look at programs and what they were trying to achieve. And I think we had 9 characteristics, but for the purposes of this presentation, I synthesized them into 8. And I think we could understand a program by saying, well, what's its primary objective? What is it trying to achieve? Is it only trying to achieve, for example, that kids grow in terms of their physical health and maybe their brain development? And in that case, is nutrition the best way? Are you also trying to develop the brain through cognitive stimulation, and you need to accompany that, as they were saying? Are you trying to get kids to read and write? And that's also, and set the basic skills for that. What's the focus area? Is it going to be at the home? Is it going to be from a center? What level of coverage are you expecting? Is this something that is going to be of universal coverage or more targeted interventions? And then the whole host of questions about institutional arrangements, financing, who are the service providers, how are we going to assure quality, and as somebody mentioned, very important, what are the challenges of going to scale and improving service delivery? How do you build those in? And so we looked at a number of programs, and we developed a way of sort of classifying them. And we classified them in 2 sort of different dimensions. One had to do with the focus areas and mechanisms of intervention, and I'll go a little bit in detail in that. But then we also classified them in terms of how complex are the institutional arrangements required to deliver these different types of programs. And and I would say, this had a title, I don't know why it's not coming up. I think because it was too busy, but I guess the title really reflected is, when is it worth trying to achieve integration, and when should you be happy to have a solid sectoral intervention? And I think this helps us think about that. So when we talk about a sectoral intervention, for example, let's say a reading intervention, we could assume that a school is perfectly capable, or a teacher, to deliver that, and it's single sectorial. Nutrition obviously plays into that, but the primary focus is really to get a child to have the basic skills for reading. Another intervention could be defined as cross-sectoral, where it's still about a specific sector, but it may require inputs from another sector. For example, in a lot of the countries I work in, children don't have access to breakfast before they go to school in their homes. So the objective is to get them to school and to make that more enticing, and obviously to have the child ready to learn. Providing breakfast at the school may be necessary. But that doesn't, that requires, let's say, minimal coordination between 2 sectors. A multi-sectoral intervention is one where you're really trying to achieve a more holistic intervention. For example, the one that she was referring to right before me, the PRO-PUN, where you're really trying to talk about stimulation and feeding at the same time in a comprehensive way. And it includes, in that case, 2, it may include 3, it might talk about maternal health, and so you're educating parents And it really requires multiple expertise, but you can still deliver it through one point of entry and kind of uniformly across different populations. It can be targeted, it can be universal, but it's the same program that you're trying to deliver to a group of people and beneficiaries. And the last and more complex one is when what we refer to the comprehensive interventions, where not exactly the same program is delivered to all beneficiaries, in this case young children, but instead what you want is to achieve, for example, adequate development at the right stage. And so you have to coordinate across agencies to ensure that children get the health interventions when they require them, the nutrition interventions when they require them, the education services when they are of age to get them, and even differentiated education interventions as well. So that what you really need is a very systematic way of monitoring and coordinating across agencies, and that's much more challenging institutionally. What are some of the challenges and opportunities that I think I see and we've learned from Latin America? Having an enabling policy environment, and I'll go through them one by one. I think just starting an earlier conversation today where we were saying that there's a lot of programs targeting the 0 to 2 group. Harold was mentioning that as well. And there's a lot of programs for 6 and older, or for 4 and older. So 2 to 4 is a vacuum. Similarly, you have in Latin America, but I think in other countries as well, lots of very good programs that are very small in scale. They're highly evaluated, have good results, but they're not scalable. And then lots of massive scaled up programs that are really not of that good quality or that impactful. And so how can we achieve quality and scale? That's still a challenge when it's appropriate. And then quality monitoring and assurance. In Latin America, at least, we have the experience in education where we expanded quite quickly, more than other developing regions, access to primary education. And we learned a tough lesson that having kids in school did not translate into having kids learn. And we're really taking that to heart and trying not to repeat that same mistake now that we're trying to expand access to early schooling and early childhood development services. And it's challenging because it requires so much quality monitoring, support, capacity building, and then ensuring that you have the capacity to enforce or assure that the providers comply with the quality standards that you have devised. So in terms of an enabling policy environment, many of our countries are moving to having a comprehensive ECD strategy that integrates and coordinates interventions in different areas. And that's really critical, is having at least the regulatory framework that says, what are the guarantees, as some countries refer to them, what are people entitled to have? That doesn't mean that government needs to provide them all. Sometimes you can rely on the private sector, and it's often important to do so because government doesn't always have the capacity to provide. A lot of countries have the issue, it's one of the challenges, I think, for integration is that it's hard to have an agency that has the overall picture. So when you have the education ministry driving an ECD program, it tends to be preschool. Or if you have the health ministry or the secretary driving the ECD intervention, it tends to focus on maternal health and child health and ignores the cognitive stimulation, parenting, education, and schooling aspects of it. So, how do you, and a lot of countries, I think, recently are moving to having this alternative figure that doesn't deliver necessarily any of the services, but has this broader perspective and is coordinating across the different line ministries. We're still not sure whether that works, so I go back to my first statement that I'm not sure. I'm talking about evidence. I'm really talking about more like patterns that we're seeing and sort of things that we're trying to see if they will work, given that this is a new area, at least in Latin America, that we want to expand with quality. And it's critical to have well-defined roles and responsibilities of public agencies involved in ECD, NGOs, private sector, which all play an important role. And finally, as you all know, adequate funding. And that's been a challenge, and it is a very big challenge, particularly because quality ECD is costly. And I think the ratios of adult and children in centers have to be high adult ratios per number of children, or small numbers of children per adult. And that a lot of countries have trouble, I think, defining policies that are universal access but will target some groups. So we're, how do you actually provide the most vulnerable children the best care first? Because kids who have better homes or more advantaged homes will have other supports. Okay, I'll go quickly. I'll stop. So in terms of the second challenge and opportunity is, integrating and implementing widely where appropriate. Again, starting with disadvantaged children is always probably the best strategy, and then expanding as you have more access to resources and more experience in how, and hopefully at least you do things well. If you're only going to be able to reach a small group, that you start with small, but as you grow. In Latin America, as well as in other regions, there's increasing interest from private sector and NGOs to collaborate, and so how to partner with them becomes both a challenge and an opportunity. And for the comprehensive block that I was talking about is, how do you have a system and a systemic way of monitoring child development so that you can then coordinate across policies and programs? For quality monitoring, I just want to really not pass that too quickly, because that's really critical. Having clear standards for early childhood development, including cognitive, socio-emotional, and health milestones. A lot of our countries in the region, when they talk about ECD standards, all they do is infrastructure. What should the centers look like, how many adults per child at most, but nothing about the interactions or about the other sectors that go along. And then very hard to do, but very important, is how do you monitor and ensure compliance with these standards. And again, not easy, but critically important, particularly in contexts like Latin America, where people who generally enter the profession of teaching or early child care providers are not the most talented professionals. How to really support them and train them well, and ensuring that they're qualified to meet standards. So I'm going to leave it at that, and thank you very much.
Thank you so much, Harold, Mandana, and Liliana. It was really, really a great set of points that you were making, and we really appreciate your presentations. I just wanted to say to the audience, both here and in webinar land, that we'll be taking questions in just a couple of minutes. And please feel free, those of you who are on the webinar, to send in your questions through the chat. I just wanted to make a couple of points on where we've been, where we are, and where we need to be going. First, I wanted to acknowledge the important role that pioneer Pat Engel played in bringing these issues of integration to the fore. As a developmentalist who focused on nutrition, it was really her life's work to bring synergies together in programming and in policy and get folks excited and really interested in working on integration to the good of families and children all around the world. If she was still with us, Pat would tell us she's very excited about the work on integrating ECD, and what she'd really be the first to say, this is very hard work. This is not easy. But it takes so much investment of time in the relationships with stakeholders and really building the support across the different sectors and at the national and subnational levels. Second, when thinking about the work today, the recently published Lancet paper on the Pakistan trial by Aisha Yousafzai and colleagues really tells us a lot about implementation. Similarly, a number of the papers in the Annals special issue talk about the role that has to be played by understanding how these programs were implemented and what we've learned about the hard work of putting together ECD and nutrition programs. So I think we really need to welcome and embrace this emphasis on the very close attention to implementation. All along, the Pakistan trial team really documented what it took to train the lady health workers to deliver the ECD and nutrition interventions, what it took to support them and document the intensity that the families actually received in these programs. This is really progress in our field, which is often running to go to the outcomes. What is the impact on children? But what we need to understand is the impact on the adults. How do the adults change their behavior with children? So again, thinking about those intermediate outcomes that lead to our ultimate outcomes of better well-being for children. The project Grow Smart in India is also featured in the Annals document and by Sylvia Fernandez-Rao and colleagues, where they're really talking a lot about interdisciplinary collaboration and what it takes. They talk about working with 3 countries, 4 institutions, and across 7 disciplines. That is really, again, a challenge, bringing all of those folks to the table and keeping them engaged and excited and taking ownership collectively of these activities. So these are examples of documenting and publishing what we all need to know. What went as expected, what didn't go as well as we'd planned, and why. Without this information, we can't build an evidence base or engage in continuous quality improvement. We certainly don't want to go back to square one every single time. We need to learn from these experiences. This seems especially true related to cross-disciplinary work because of the effort and cost involved in making those types of interventions come together. Finally, I think nutrition may actually be our easiest health sector for integration. Because feeding, as we've heard, and stimulation go so nicely together to support parents in helping their children learn language and also in developing that crucial parent-child bond. But what about those areas that have been historically more challenging? Child survival, care for illnesses, services for children with disabilities. Pockets of these types of interventions really do occur and are happening around the world, which is very exciting. One example that we saw up close in our UNICEF study was Community Integrated Management of Childhood Illnesses, CIMCI, that added in modules related to ECD, very similar to what that was included in the PEDS trial, the Care for Child Development modules on stimulation. So we've really heard from our experts here today and thinking about where we are so far about what it does take. There's a lot of work to do, and what we're hoping now is to open it up, get some questions from our audiences to our panel, and also some sharing that you might have from your own experiences. So I think what we'd like to do now is take some of those questions, but we'd like to put a little bit of a constraint on you. If you would, please introduce yourself and your institution and provide one comment or one question, because we like folks to be able to, as many as possible, to be able to engage with us. We are doing pretty well on time, so that's great. How about any questions that we have here in the room to start, please? And we have a mic right there.
Thank you. Jess Wilhelm, formerly with the Peace Corps and IFPRI, currently with Social and Scientific Systems. Although we're working with developing countries and focusing on developing countries, what have we learned from developed countries' experience of integrating services, social services, health services, and education for young children and families that can be applied internationally? Thank you.
Wow, and I didn't even ask him to ask that question. My background is in US-based work, so I'll speak a little bit to that, and maybe other panel members have some reflections on that as well. One of the major initiatives that's been going on for quite some time is related to early childhood home visiting. There's a major investment from the Affordable Care Act in maternal, infant, and early childhood home visiting, where the government asked for a systematic review of the evidence on a number of whatever models were out there. Mathematica actually conducted that review and put forward the evidence across many, many outcomes, across many, many different types of settings, and categorize them as far as the levels of evidence. The Department of Health and Human Services then went ahead and selected those that met a bar, an evidence bar, and states were allocated funding to go ahead and implement the ones that they selected. That is an ongoing process that's been going on over the past few years. It involves the integration of HRSA, the Health Services Resource Administration, and the Administration for Children and Families. So that was one of the things we talked about. Who has to be at the table to try this integration? This is integration that's coming from the top down, but really is responding to bottom-up demand for these home visiting services. And nurse home visiting is one example, paraprofessional home visiting, where folks are going into the homes when before baby is born, getting to help parents to understand to go to take these the prenatal visits, take up the supports that are available to them, and learn about early childhood development. I would say if you were to grade the experience here, it's probably a growing pains situation where it's difficult. It's not so easy to get all of those perspectives through. Similar work is happening in Central Europe. Deepa Grover and folks at UNICEF and WHO there have been working very hard to pull together home visiting experts from around the world to inform home visiting programs there as well. But to do, like we were talking about here, taking that information and making transitions for children, linking things together a bit more than they have been, so that you're doing the handoff that Emiliana was talking about. Anyone on the panel want to address this question of what you're seeing as application of what we've learned in developed countries to developing world countries?
I'll take a pass. What you've said about how to actually administer is an important issue. I'd say there's two other issues that come up in one caveat. This is one of the very few discussions, even though it's a very short one, that hasn't put up a curve that's attributed to James Heckman and his colleagues, which show the economic rate of return to investing in education declines continually from early childhood right through to training, vocational training. And that is a meme, I don't know the right word for it even. It's a theme that runs through much of the ECD literature. It's based on a very small bit of evidence from the United States. One thing that has come out of that set of studies, it's a very large set of studies that's been done, is the importance of social emotional development, what economists tend to call non-cognitive. I'm always, my wrist is slapped when I do that outside of economic discipline, but it's the same thing. That's as important as the cognitive, which we have better ideas of how to measure it. So that is something that fits right through, that has come from the United States, that has translated into work that I've seen in developing countries. The one caveat I'd like to mention, the most documented study, CETSA study from the United States, the program cost $8,000 US, $2008, something like that. You're not going to see that in Mozambique in my lifetime, I'm afraid. No program, or you pick any other ones. What? Per kid, yes. Oh, thank you. Yeah. You're not going to see that in Africa. You're not going to see that in Asia, maybe Singapore. I don't know if they have, but you're not going to see them in the low-income countries. So we have to find out, even if we've learned some lessons on how to administer and learn some lessons on what we need to be tracking, we have to find other ways of cost-effective ways of delivering that can be done where the cost of a program can not approach what can be done in the United States.
Thank you so much. Do we have another question here in the audience? Yes, please.
Hello, my name is Amber Davis, and I'm a summer fellow here at Mathematica. I'm a current PhD student at Howard University School of Social Work. And my question is in regards to, it's kind of related to cost effectiveness, but I had wanted to know, like, when you all are doing the research, how often do you all consider indigenous forms of early child development that are practiced in the countries, particularly, related to social development and resources and just being, culturally aware when you come, with dominant views of what should take place in countries. So that's my question.
Thank you. Panel?
In Latin America, where I work, this has been a big issue, and for the last 3 years, the IDB has been investing in a program to collect and design regional indicators for early childhood development. And it's finalizing this year. We presented it with Kim and Amanda in a different academic conference, but we're very excited because it's, I think, a serious effort to measure the kind of cognitive and socio-emotional development of young children in rural parts, some of them with indigenous backgrounds, in a way that is culturally adapted to their context. And so I think that's been a big effort. In our interventions in many countries, for example, we now have an operation in Peru, which is primarily in remote areas, to expand early preschools, early childhood centers and preschools. And a lot of the children don't speak the language of instruction. They have another language at home. And how do you deal with that? And so we're learning from other countries also, many countries in Africa that have dealt with this kind of issue for a long time, and trying to integrate that in our programs. So yeah.
Okay, any more questions for the panel? We have a couple questions, real challenges coming up, but yes, Amanda.
Can I ask you're right, thank you, sorry.
Please introduce yourself.
Oh yeah, here we go. Hi, I'm Amanda Beatty from Mathematica. And there's one question from a webinar participant that I'm going to take some liberty to interpret because I'm not exactly sure about it. And then I also have a question if we have a minute. So this person's question is asking about mobilizing the nurse workforce. So kind of what impacts could actually, or how do you think mobilizing midwives and training midwives could actually have an impact on some of these, maternal and child mortality outcomes? I think there's been a lot of work on that, and my guess is that this panel would support that, but would love to hear what they have to say. Should we do that one first?
Yeah, that sounds great. Who would like to take that one?
Okay, so I think definitely it's been recognized that you can't really have only a focus on highly trained, physicians, for example, to be the main focal point. This is recognized for nutrition interventions, and I think it would be similar for child development as well. One of the papers that we had in the annals actually specifically looks at training of paraprofessionals and using community health workers and nurses and in the urban rural health centers to deliver integrated programs, and definitely there's a very strong role for them. As I mentioned at the end of my presentation, though, capacity development is really, really important. I mean, these are basically professionals who already have a full list of things that they have to deliver in every visit, and they need job aids and supervision and supportive supervision in a way that they're enabled to take on more and be responsible for additional elements in the program. So that needs to be a thoughtful decision before we start a new element to be implemented through these paraprofessionals.
Amanda?
Okay. So thank you. So my question is about this message overload that Harold brought up. You can correct me if I'm wrong, but my interpretation of the Pakistan study or the findings is that the cognitive effects were higher for kids who got stimulation alone than for kids who got stimulation plus the micronutrient supplementation. And the authors note that maybe this is because there was this message overload that when you actually tried to combine these two interventions, it actually had less of an effect. So that's pretty concerning. So my question is, where do we go from there? That's one study. Would you try to kind of vary the number of messages in terms of research? How would you actually try and look at that further? Because it seems like this is, it's a strong study and raises a red flag, at least to me.
couple of things I'd think about that. First of all, many of the smaller studies show that the training that is needed to achieve results is also greater than was in Pakistan. So that it may be that if you can increase the training of the service delivery, you can get better communication. I speculate, obviously, because that hasn't been, there wasn't a trial looking at how much time. The same thing, the number of visits that have been shown from group sessions. I don't know where I've seen it, but 14 is sort of a number of contacts in group sessions which are supposed to be a target. I'm not 100% certain of that number because I can't quote it, but I remember having some conversations on that. So that's an issue as well, but that we do need to find out how to communicate better. And another piece of evidence coming from a very different literature, I have looked very extensively as part of the Lancet series on education and nutrition, maternal education. And it turns out that there's very little impact of even primary schooling on nutrition. I always thought there'd be a lot. The more educated the mother. It turns out that it doesn't kick in till 6 or 7 years of schooling. Now that could be because the schooling doesn't even half the people who've been to school are not literate or whatever the numbers are. That's a major problem still. But it could also be that the complexity of messages that are given are not as simple as we'd hope them to be. So you really need to have a fair amount of experience before you can process this information. If that is the problem, at least part of the problem, then it means that there has to be a better examples of communication. Some of that is just actually spending time with the caregiver and working with her in demonstration rather than in verbal messages. You demonstrate as opposed to lecture. There's a lot of work that needs to be done on the communication strategies. And that's a long-term research need.
I think I knew her. Does anyone else have a comment on that one? Miliana, Montana?
Should I ask a question?
Sure, please.
Okay. So this relates a little bit to a bunch of issues that have been raised here. Hal, you talked about the cost issues and cost considerations. Mandana, you talked about capacity and having to train people. There's also, someone raised the issue of nurses and midwives versus in a lot of countries you have much, much lower skilled community health workers who barely have 6th grade, 8th grade education. And when you think of the nurses or the midwives, there's often a capacity shortage too. They aren't there everywhere, whereas you tend to have the lower level of community health workers more abundantly there. And I think in the U.S. early on when David Old started the home visiting thing, it was the nurse home visiting practice. Kim, you know more about this than I do, which showed a lot of impacts. And then I think they tried to replicate some of those studies using lower qualified people, and I'm not sure that they always found the same results. So I guess all this is leading to how do you identify, Harold, or the point you were making earlier, how do you identify what skill set, what the it is? We're talking about testing things and we need more research, but how do you identify what skill set is needed? It's got to be done in a cost-effective manner. If you want to do it at scale and then you have reasonably not that qualified set of workers who are even struggling to provide basic information on child survival and nutrition, how do you, is that a challenge too sectorally because the capacity, there's the capacity issue, but then how do you train people up if you need different levels of skills to deliver different types of services?
In regular schooling, this has always been a big challenge in terms of how do you identify effective teachers. And we know now that the easily observable variables like education and experience and age and whatever else doesn't really explain a lot of the differences in teachers. And The government of Ecuador about 3 years ago started partnering with us at the IDB to try and identify what were the characteristics of effective preschool teachers. And we have done what's really interesting. It's basically a randomized experiment, we've randomly assigned teachers to students and then observed the interactions and what happens in classrooms for 3 years with first and children who enter kindergarten, and then as they move on to first and second grade and the new cohorts. And the findings, which are just being, the first working paper has just recently come out, really show quite interestingly that, again, it's not the observables, but it is those interactions between adults and children that make a big difference, and that the teachers who systematically interact in ways that this observation method called CLASS, developed in the University of Virginia by a team of researchers and applied in the MET study that the Gates Foundation funded in primary and secondary here, or at least, primary and secondary. It's the first time it's applied in preschool. But those teachers who are most effective in getting kids, for example, to learn are also more effective in getting kids to have the executive functions, these socio-emotional skills that we value so much. And so, and they do that regardless of who are the children assigned to them. So because we were able to, with the government of Ecuador, assign children randomly to the teachers, we have the same teacher with different groups of children over time, and we see that that same teacher who, according to the CLASS method, is doing the correct practices or the practices, is also getting the kids in several dimensions to be more effective. How do you scale that up? That's a big challenge, because this experiment has been really, time-intensive, resource-intensive, and costly. And I guess the hard part about it is that it's really hard to go from what you do in a classroom to then how do you test for those skills in a person that you would like to bring into the profession, whether it's teaching. And so we are working with the government to translate that in some sort of selection instrument that would allow them to select better teachers from the start. But we'll see where that takes us.
I think for me, it's difficult because you think of a quote-unquote workforce. We think about that here in the U.S., but we're talking about volunteers, right, in rural villages, in Cambodia, in Africa, everywhere. And I think part of it is the question of how do you see are you an integrator from the start, or are you coming from your sector? So I think that might be something else for us to consider is it a new position, or is it a position where something is grafted on? And how it's presented, I think, to people to make them feel comfortable in that role. We know from here in the U.S., a lot of the public health nurses had a bit of a difficult time saying that they were going to be teaching about, about the bonding experience, about particular early childhood stimulation and cognitive development supports, just because it was out of their comfort range. So I think that's a great question, Anu. Thank you so much. We have a couple of questions that we had for our panel as well. I'm going to give them a couple of minutes to react to them before we go back to some open discussion. They are, how can researchers and practitioners work together to build the evidence base that's going to best support governments and policymakers in knowing what to try next, what to keep on trying? And also, what can the organizations that the three of you work with, and those of you in the audience, do to support this kind of integration? Harold, we're going to start off with you, okay, if that's okay? And you can stay in your seat if you like.
Right, okay, I was supposed to put my last slide up, but it's up, I see. I think one of the research needs that's out there still is understanding the costs. I mean, we understand what it takes to put iron fortification in bread in Chile. It's the same as Uzbekistan. It's pretty standard. We can understand, again, salt iodization or what have you. What's the cost of delivering the interaction, the behavioral changes that we're talking about, as one person in the audience said, designing it to be locally sensitive is important, and then how to deliver it. What does it cost to do that? There's very little out there yet on how to do that. And clearly, you go to the Minister of Finance or the Minister of Education and say, you need more ECD investment. They're going to ask, what's it going to cost us? It's a fair question. And unfortunately, what there is out there on cost is quite variable, going back to the point that Emiliana just made, that we really know little about the quality, so that it's not clear that doubling the cost of training increases the quality if we don't know how to do that yet. So that's one area that needs to be understood in how to figure out how to make quality of the service delivery and what is it going to cost. The parental enrichment, because this is behavioral change. Again, it's quite different than a nutrition supplement. It's very tangible. You count the number of iron supplementation tablets that are delivered, how many have been taken. You know what you're doing. It's very different for parental enrichment to say, well, interact with your child. That's a different type of message, and we don't really know how to do that at scale yet. And that right now there's a number of studies in the field, many of them in Latin America, that are trying to do this for group sessions, trying to do this for communication, because I think the home visit model, which we know does work, is harder to bring at scale. And then the other question that I've already brought up is just to have a seamless transition or transition. Who is responsible for service delivery in the first 1,000 days? Who's responsible in the preschool, which is often private in many countries, as opposed to almost all the primary schools are public. There's private alternatives, but there's always a public, but there's not always a public preschool. But the transition between, there's no private services, very little. There's little daycare services, but the daycare services are much more about keeping the children safe or allowing the mother to work than it is about stimulation. So how to have a complete program, which goes back to the policy points that Emiliana said, a complete program that has considered from what we know about nutrition, what we know about preschool, to what we know about child development, is still a major gap.
Thank you so much. Manda, would you like to go next to talk about those two questions?
Sure. In terms of what we can do to really build the evidence base, I think really the first step is actually to develop and communicate a common research agenda, to actually identify the gaps and communicate it and make sure that we are all on the same page and we bring our resources together. And I think that especially again in this intersection of health, nutrition, and child development, there is a lot of good progress there, and it seems that we are coming together around some common topics, some common gaps that all of us are going to address, and that would be really important in building the evidence base. To our work, what has come out of the development of the series and the next step for us, one of the big gaps that was identified was not having global indicators for population level assessment of child development. And I myself, when I was at UNICEF, I was involved with development of the indicators for infant and young child feeding practices. And I did observe and experience how important that was in actually convincing governments to include it in their large-scale surveys. And once you start reporting on issues and being compared to other populations, I think that does make a difference. It allows you to raise issues, and so there has been some good work done for child development indicators, and we will be hopefully contributing more to that in future. To have that as part of the post-2015 development agenda, to be able to actually really have some goals set for the global community for child development to aspire to. So, while we recognize that there are very specific context-specific, community-specific characteristics of child development, we have to be aware of those and design and develop our programs based on those. I think there are some common elements that we can actually identify and really track on a large scale, so that there are some basic issues that we have to be able to report on and identify where the gaps are. So, we can ensure the rights of children and equality are all ensured as well. The other thing that's of great interest to me, also working on the intersection of sciences, we are the program of an Academy of Science. I think it's, I always think about, well, interdisciplinary work, it's nice and good, but it's quite difficult, and it takes a lot more investment in process as compared to the amount of investment in time and other resources that you can actually put in the actual research. So, just creating more recognition and trying to bring some creative resources towards investment in better processes, better engagement, discussion, connection, maybe having collaborative research proposals, collaborative research grants in a way that it would encourage more work across disciplines. And that's, I think, a bigger, more ambitious agenda for us being an Academy of Sciences, but I think we can do more advocacy for that kind of work.
Great, thanks so much. Emiliana?
The question about how we can work with practitioners and researchers to improve the research base. I think that it's really important to do research on questions that are very important to policymakers and to practitioners. And I think a lot of times when I would say the fad for impact evaluations really took off in developing countries, many institutions, including where some of us have worked and where I work now, really we're so excited to be able to attribute the impact of something to an intervention that sometimes we evaluate things that really weren't that meaningful, that wouldn't be scalable, where the evidence in the end wouldn't be informative for policy. And one of the exciting things about the Ecuador example that I was giving is that when my colleagues talk about it who were there from its inception, they say the whole idea of assigning children randomly to teachers came from the Minister of Education at the time, who was not an economist, who was not a social scientist, but really understood that unless she did that, she wouldn't know whether it was selection into class, And so she really cared about the questions that this research project was going to address. And in fact, the research project kind of was generated as a result of previous research that had documented the huge gaps in cognitive development of children in poor households in rural Ecuador and in wealthier households in rural Ecuador. So the project's called Closing Gaps because there were these gaps that were very well documented that were, that what became a policy concern. So I think, the first thing is really where they're, focus on those questions and then find the methodology rather than go with a methodology that you really want to use and test and then, compromise the results. I have so many examples of the latter. I also think that there are benefits to recognizing that the integration and having sort of the ideal intervention may not be achievable from the start, and that some graduality, especially as you take to scale, may be necessary. And sort of there, the issue of monitoring and really understanding what's happening is really crucial. We're working closely with the Chilean government, and Chile in Latin America is seen as one of the more solid earlier adopters of a comprehensive program called Chile Crece Contigo that really was about providing 0 to 8, comprehensive interventions and everything. And even though it's seen as a great program, it hasn't fulfilled its promise, and there's not as, there's a recognition that more is needed, that we need to scale up early or access to early care, that early care needs to be of high quality, that preschool needs to be of better quality than it is, even though access at 4 and 5 is almost universal. So, I think that's okay too, as long as you have kind of the right objectives and know that you're not going to achieve them overnight, but keep tracking and improving. I think that's sort of also important.
Thank you so much. Maybe we have time for one more question. Any questions here in the audience? Yes, thank you.
My name is Sylvia. I'm an independent teaching artist. Can I speak not on the microphone? Does everybody? I need to speak on the microphone.
Yeah.
Okay. Have you considered, and as Harold Wright had mentioned, that there are certain things that you needed to demonstrate. They need to really learn in an experiential way. And we talk about integrating, but are there attempts or programs, community programs, that bring together different groups, the less advantaged and the more advantaged, so they learn through that interaction about everything, about the social, emotional, cognitive, of how to nurture, et cetera, et cetera?
I don't know of anything that fits what you described. There are community approaches, but they are not, they aren't meant to have cross-community sharing of information as I think you're describing. I'm not aware of any of that.
No, I was just following up on what you said, because going on a home visit, it's very isolated. So I just wondered if there is any research that is being done and tracked in bringing groups together where less advantaged parents actually learn by observing and interacting through the guidance of a well-qualified teacher, or maybe through play or through arts classes for young children that would also cover that gap from 2 to 4 and include daycare caretakers and fathers, and just track if the level of understanding of early childhood development of those less advantaged just by interacting has heightened.
Well, there are group programs for demonstrating play, interaction, and so forth, which are not home visits, but at a center. But I don't know, again, because I think you're describing not so much learning from a service provider, but learning from other caregivers. I'm not familiar with approaches that have emphasized that, but the fact that I'm not familiar with it, I haven't asked. So it may be I'm not familiar because I haven't looked in the right place. So ask my colleagues whether they are familiar.
Well, I know there are some approaches, especially I talked a little bit about it in terms of women's empowerment in order to improve caregiving practices, but also for women themselves. And in those empowerment techniques or approaches, a lot of it is about peer support and learning from each other. So really, mostly the system is just supporting this interaction and providing the basic needs of these groups, but really allowing the groups to interact with each other and support each other. And there have been some good examples from there. For behavior change in nutrition as well, group interventions have been seen to be very effective. For example, for breastfeeding promotion, you can have group settings rather than, as you said, individual kind of more isolating interventions. So that's something that has been used and explored, and it has been effective.
Well, I'm going to have to step in here and wrap up. I'm going to pass it to Anu to say some final words. But thank you so much for the discussion. Thank you, audience.
Thank you all so much. Thank you all so much. I think it was a really interesting and stimulating discussion. It feels like we're just at the beginning of a research agenda, and we have a lot to learn. I think there were several takeaways, and I was just trying to jot a few down. But I think a couple of sort of big gaps really emerge as this seamless transition and not having something in this 2 to 5 year range. And I think thinking a little bit harder about interventions or which sector would pick that up, I think came as something really important to me. And also, I think, Emiliana, this comprehensive top-down policy, sort of thinking about it more globally rather than kind of driving it from the grassroots level. So, and of course, the questions related to scale-up, which I think permeates all development work, not just this area. And of course, the need for more research, and I think the disciplines traditionally have been separate, and so not just in the field getting people together, but even in the disciplines getting people together. So I think this was a very, very stimulating discussion, and hope that that there is continuation of this research agenda, and that sometime down the road we're able to have another convening where we have a lot more results and progress to report on. So overall, to the audience, thank you so much for coming and attending. We hope you enjoyed today's discussion. There are some comment cards in your packets and in the electronic survey that's offered to the webinar audience. So we would love for you to fill those so we can improve these take your suggestions for future webinars, and hope to see you at our next CPRE forum. Thanks very much.